Welcome to the voiceover PowerPoint and abnormal psychology on mood disorders. It's chapter 5. So when we're talking about mood disorders, there are mainly two major types or broad types. One involves only depressive symptoms. The other involves manic symptoms. And those are bipolar. So you have the depressive disorders and the bipolar disorders. And then so there's a list of the different types. One of the things that you want to remember is that when we're talking about depression or mood disorders, when you're into the clinical disorder, that this is serious stuff. It's not about being in a bad mood or feeling blue for a day or two or even a week. Okay, they make people feel terrible about themselves, but they can be treated and treated successfully. So the next slide will have a short TED Ed talk about depressions to help you get a little more rounded picture about what we're talking about. And here's click on this slide. So the major depressive orders, and as you go down the list on the left over here, one of the things that you notice that's in the DSM-5 is that everything is about time. Okay, so 5 or more symptoms that last for more than 2 years, or 2 weeks, then 2 years for the persistent disorders. And bipolar disorder is one lifetime manic episode. That's bipolar 1. And then bipolar 2 is at least one manic and depressive episode. And then the recurrent mood changes, the cyclothymia, is something that goes from high to low over 2 years. And this is what generally we're talking about when we talk about people having bipolar disorder. It's not a one-time incident. So the major depressive disorder, or MDD, you have that sad mood, loss of interest, loss of pleasure. People complain they don't feel anything. That's anhedonia. And then these are the symptoms. So it lasts for nearly every day, most of the day, for at least 2 weeks. More distinct, more severe than a normal response to a significant loss. I mean, so if you have a death in the family, it's understandable that you would be depressed. But this is longer lasting, more serious, plus you add in at least 4 of the symptoms listed below. Okay, you have to have at least 4 of them. So the MDD, the symptoms do dissipate over time, so there's more like there's episodes of it. Once you have an MDD, a major depressive disorder, it's likely to come back. And in most cases, you need help getting out of that disorder. The lucky people are the ones that recognize they're in it, and they go back to see their clinicians, get some medication tied in with therapy, and can climb back out of the hole that it puts them in. There is a subclinical depression, and that's that overwhelming sadness plus 3 of those other symptoms. for at least 10 days. The persistent depressive disorder goes on for at least 2 years in an adult, plus 2 of the other symptoms. And there's no manic part of it, so the bipolar is not present. So there's a list of different depressive disorders, and I'm not going to go over each one of them, and I'm certainly not going to read you the symptoms that you can find in the book and so forth. You do need to know that there's differences between these disorders, and especially for some reason people get depressive disorders and ADHD confused, and I think it's because of the ADHD gets confused quite often with bipolar, and then bipolar gets, because it does have a depressive component, gets confused with depression. So where does it come from? What's the epidemiology? We're not quite sure, but we do know twice as many women as men have depression. When I say depression, I'm talking about clinical depression. It's 3 times as more common in people that are in poverty. It varies across cultures. For Hispanics or Latinos that were brought up in Mexico and come to the United States, they have a much lower rate than Latino or Mexican descent people who are born in the United States. So our culture has something to do with it. And 2/3 of the people suffering from MDD will also have an anxiety disorder at some point. So the bipolar now is different in that it adds the mania to it. So bipolar disorders used to be called manic depressive disorders, but now they recognize that it is absolutely brain involved. Okay, while yes, you must have a psychotherapeutic component to overcome it. It is a brain disorder, and so that's why, as you'll see in a minute, the pharmaceuticals can be extremely effective for bipolar. One of the challenges with bipolar is that quite often, we talk about the comorbidity of things, quite often people who are bipolar self-medicate with alcohol to control the mania, and as we will discuss many times, there's something about depression that people think if they drink something they're going to feel better about themselves or the situation, and in fact it just makes them more depressed. But they continue to try to blot out the pain with the alcohol. So alcohol and alcoholism becomes a self-treatment mode for a lot of people suffering from depression and bipolar. So here's what we were talking about a little earlier with the ADHD versus bipolar. Recognize ADHD is not a mood disorder, but it does have an overlap. You see the thing in the center, the irritability, hyperactivity, restlessness, impulsivity, being oppositional, increased energy. On the right-hand side, you can see what some of the differences are Um, the You need to recognize also that that in bipolar disorders, these mood swings can be rapid cycling. You go from one to the other, but in most cases, they're depressed perhaps for weeks, and then manic. Usually not as long as they're depressed, but it certainly can be for a week or 2 weeks until they kind of wear themselves out. The manic stage, quite often, people that suffer from bipolar like the manic stage. They get a lot of stuff done. They're very effective. So they don't want that to end quite often, which is another challenge with treatment. So where does it come from? I don't know. It's about 1% in the U.S. And up to 4% for the cyclothymia. The average onset is in the late teens, early 20s. Late onset bipolar is generally tied in with alcohol abuse. So, as a minute ago when I was talking to you about treating the bipolar with alcohol, people who are heavy drinkers or alcoholics for long periods of time also can, in their mid to late 40s, develop bipolar because the alcohol changes the brain. No real gender differences other than the women to suffer more depressive episodes. So the biopsychosocial factors all contribute to the vulnerability of a particular person. Then you add a particular stressor, and that's when the mood disorder makes itself visible or felt. So from a neurobiological standpoint, about almost 40% can be inherited, and you look at the bipolar, it's up to 93%. Okay, so if one parent suffers from bipolar, there's a good chance a child could get it. If both parents happen to suffer from bipolar, it's almost assured that the child or children are going to be subjected or to acquire bipolar disorder. Again, when you look at the neurobiological factors, the neuroendocrine factors, I'm not going to go into all of the different things. A lot of it is listed in your book. But the important thing to know that there's almost discoveries every day when it gets into the mood disorders. They're learning stuff all the time about how these chemicals in the endocrine system and in the neurobiological, in the brain, the neurons, neurotransmitters, and then the dopamine, the serotonin, the norepinephrine, etc., how they all impact each other or work or don't work, and what they can do to mediate or modulate them to help people with depression. Social factors, stressful life event, lack of social support, high levels of emotion by family members, marital conflict, rejection. So all of these things fit in to contributing toward a mood disorder. So a big question is, why do some people become depressed after a stressful life event and others do not? We don't know for sure. We suspect that some of it has to do with social support. Some of it has to do with the person's neuroticism to begin with. There are several cognitive theories about how people think that goes along with it. And then, of course, there are the heritability challenges. Some of it's inherited. So the cognitive theories, you got Beck's theory, which is the negative triad, which is a negative view of yourself, the world, and the future. And that creates a negative schema where you see the world negatively, and then that leads to biases that make you depressed. Hopelessness. I think that's the pretty much accepted that the biggest trigger for depression is hopelessness. And then attributional style, when you look at optimism versus pessimism, if you make global attributions that everything is wrong and nothing is going to go right, then you fall into that hopelessness category. Now the rumination theory, we talked about in positive psychology, the difference between rumination and processing. Rumination is thinking of things, of events, and so forth, and reliving the emotion that goes along with that. So it's like staying in the sadness, staying in the fear, staying in the hopelessness. It's brooding, okay? And all of those are the cognitive theories that lead to mood disorders. And from a cognitive standpoint, it's a matter of just making sure that your thinking is correct. Your thinking is positive and not toward the negative. So you have similar challenges with the bipolar. Negative life events, neuroticism, negative cognitions, lack of social support. The mania, there's a reward to the sensitivity. What that means is that you get positive feedback. As I said earlier, the people who are in the manic phase of their disorder like it. They feel good. It gives them a lot of confidence. They feel like they get a lot of things done. They can be very successful in that stage. So that's one of the positive feedback is part of the mania. And then of course with that too, though, there comes sleep disruption, and that will eventually lead to crashing. So how do you treat these? CBT is the most common method. Cognitive behavioral therapy, cognitive therapy, learning to replace the negative thoughts with neutral or positive thoughts, focusing on your self-talk, adding mindfulness meditation. And what the mindfulness meditation does is teach you to focus on your thoughts, to be able to get rid of, to control what's coming through your mind. As I've often said when I'm talking about the cognitive therapy, there's 10,000 thoughts a day come through our head, or actually it's 50,000. Excuse me, 50,000 thoughts a day come through. We can't stop them from coming, okay? But we can choose which ones we will focus on. So if I tell you, don't think about a white polar bear, oops, too late. You're already there. But you can now dismiss that. You don't need to think about it anymore. And that's what the mindfulness meditation and the cognitive therapy strive to do. And then there's working with couples, because a lot of times one person feeds into the other person's etiology or mood or disorder. The psychology, psychoeducation, family-focused treatment, these are all parts of different approaches. Again, they all kind of fit under some type of cognitive behavioral problem solving. Now, from a serious standpoint, or more serious, ECT, electroconvulsive therapy, is back in vogue. Any of you that have ever seen the movie One Flew Over the Cuckoo's Nest, you get the impression that it's a pretty barbaric treatment. It does seem to help in certain cases, but it's for people that don't respond to medications and cognitive behavioral therapy, and they're not quite sure how it works. Along those lines, and not nearly as severe, something that's just been brought about in the past few years is the transcranial magnetic stimulation. And that's where a magnetic coil is placed against the scalp, and the magnetic waves are pumped in, and it seems to provide a temporary relief that may grow into a more permanent relief. And some people even have electrodes implanted in their head so that they can have that electromagnetic field kind of all day, going on. That's a little extreme, but in some of these cases are very extreme. So what are some of the pills, the pharmaceuticals? One of the things that seems to work very well for bipolar is lithium, which is it's really a salt, and you can, like anything else, you can take too much of it, but it's not it does stabilize the moods. It's not as addictive as some of the other mood stabilizers and and certainly not as addictive as some of the antidepressants and antipsychotics. The mood stabilizers all have serious side effects, and one of the side effects quite often is suicide or suicide ideation, and so you have to. These things have to be closely monitored, and over time people find. But when they work, when they seem to work, they work very well. So the bottom line for this slide is that with the major depressive disorders and bipolar, CBT cognitive behavior therapy mixed with antidepressant medication is the most effective way. I have a family member who suffers from depression, and she will say that when she knows she is going into depression, she'll go see her psychologist, our psychiatrist, and she'll say that she needs the medication for a while just to help pull her out of the hole that she's in, and then she gets off of it and she's good for a year, maybe 2 years, and then then she has to go through it again, unfortunately. But she's learned over time to recognize when it's there and when she gets into these things, and she says it's the medication is like a jump start for your car. Without the medication, the talk therapy, cognitive behavioral therapy, isn't strong enough on its own to get her out of the hole that she's in. Suicide. Okay, so a side effect of depression is suicide. In our correlation and causation, depression does not cause the suicide. So it's important to get the terminology straight. Suicide ideation is the idea or thoughts of killing yourself. An attempt is when you do a behavior intended to kill yourself. Suicide itself is obviously the death from deliberate self-injury. And there are non-suicidal self-injuries, people cutting and so forth, that people do not have the intent to kill themselves, but actually it could lead to death. So the suicide rate is about 1 out of every 10,000 people in the U.S. in a given year. About 10% of the people report suicide ideation at least once in their lives, and 2.5% have made at least one suicide attempt. Men are 4 times more likely than women to actually kill themselves. Women are more likely to make suicide attempts that do not result in death. And it just means usually that men use guns or hang themselves, women use pills and can be brought back. If people find them early enough or they don't take the right amount. Suicide rate increases in old age, and what that means is that elderly people, when they reach a certain point, and whether they're hopeless or just don't want to go on because of pain of a disease or something along those lines, when they attempt it, they mean it, and they're successful. Unfortunately, the rates for adolescents and children are going up, and then of course being divorced or widowed elevates the risk 4 or 5-fold. So half of the suicide attempts, people are depressed at the time. That makes sense. I mean, if you're feeling great, you're not likely to commit suicide. There is a heritability component. Social factors have a big impact on it during recessions, and then media reports of suicide. It seems to start a copycat situation, and then the people that just don't know how to problem solve, are hopeless, have low life satisfaction, and are impulsive. all of those fit into the risk factors. So some of the myths about suicide is that people who discuss suicide will not actually commit suicide. That's wrong. Most of them communicate that they're going to do it somehow or another. The myth is suicide's committed without warning. No, people usually give warnings. We may not see it as that. The myth that suicide people want to die, probably not. Most of the people that where the suicide is prevented and they have a time to step back from it, they're thankful that it was there. And people who attempt by low lethality means are not serious. That's wrong. It's just people are misinformed, don't know about pill dosages, and they just don't do it right. So if you look at the self-defense, the gun poster, and the number one thing guns are used for in this country is suicide. Okay, out of all of those things, there's only 230 justifiable homicides. That would be things that are self-defense. So how do you prevent suicide? You talk openly, matter-of-factly, especially if somebody has tried suicide before and made an attempt. It's similar to what we will discuss when we talk about people suffering from addictions and so forth. If you ask somebody that's in recovery from an addiction how they're doing in their recovery, and they get defensive and tell you it's none of your business and so forth, they're probably leaning towards a relapse. Same thing with suicide prevention. If you can ask them just matter-of-factly, how you doing? Any thoughts of suicide and so forth. I mean, don't make it constant, but it's part of, they should be able to talk about it. So in the next voiceover, we'll be talking about anxiety disorders, which are probably the next largest group of disorders. So I'll see you then.